2020 begins another exciting year in the field of genitourinary oncology, including for prostate cancer, where we've made significant progress with several recent FDA approvals. I am joined by a panel of my colleagues, all experts in treating advanced prostate cancer. Today, we are going to highlight recent clinical data and discuss practical implications for patient care. I'm Dr. Neil Shore, Medical Director for the Carolina Urologic Research Center in Myrtle Beach, South Carolina. Today, I'm proudly joined by Dr. Pedro Barata, Assistant Professor of Medicine in the Department of Medicine, Section of Hematology and Medical Oncology at Tulane University in New Orleans, Louisiana. Dr. Nancy Dawson, Professor of Medicine and Director of the Genitourinary Medical Oncology Program, Georgetown Lombardi Comprehensive Cancer Center in Washington, D.C. Dr. Alicia Morgans, Associate Professor of Medicine at Northwestern University, Feinberg School of Medicine, and Dr. William O., Professor of Medicine and Chief of the Division of Hematology and Medical Oncology at Mount Sinai Health System in New York, New York. Everyone, thank you so much for joining us, so let's begin. We're going to go through sort of three different discrete areas that we are very all familiar with, but it's really kind of changed how we think about managing patients, and we've had a lot of breakthroughs. And with these breakthroughs, we also have a lot of questions that are not really clear right now on how to move forward because we lack sometimes level 1 evidence. Trials are coming, more evidence and presentations are forthcoming at our major meetings. And so it's been a really exciting time in the world of prostate cancer, particularly advanced prostate cancer, with great breakthroughs. So I think this should be a great discussion. So we'll kick it off in the first segment with talking about metastatic castration-sensitive prostate cancer, or what some will call metastatic hormone-sensitive prostate cancer. So let's begin, and first, William, if I can ask you to begin. ADT, the cornerstone, the mainstay, the foundation of advanced prostate cancer since Huggins and Hodges. But let me just ask you, now that we have all these kind of couplet therapies, talk to us a little bit about the timing of couplet or additional therapies with traditional monotherapy ADT. And then maybe we'll all talk about the notion of T levels and when to check, et cetera.
Thank you, Neil. Thanks for having me on this panel. The main essence of treatment is to deprive the cancers of testosterone, and that, as you said, has been known for 70 years. As soon as a patient presents with metastatic disease, even if they're sensitive or symptomatic or asymptomatic, they should be started on ADT right away. The studies have looked at some lead-in period to start a second treatment, and there's no optimal time, but usually in my practice, I'm going to try to get a second treatment in as soon as possible, whether that's chemotherapy or novel AR-targeted therapy. But because we're dealing sometimes with pain and with other side effects, I don't think it's mandatory that you have to start in the first visit. You really have to have time to get these drugs for these patients. There's a process involved, and you want to be able to follow these patients on a close follow-up. So I think within the first few months of starting ADT, you generally want to make a decision about and probably start one of these novel therapies.
Yeah, and I think it's a great point. Oftentimes, it's challenging if you start two things at the same time, how do you discern tolerability and patient responses? Nancy, do you have any concerns about starting, couplet therapy as opposed to monotherapy? And how do you dialogue with patients about that?
Well, quite honestly, the first time I see a patient and we're just starting therapy, after we've had a long discussion, they're a little bit overwhelmed. So I have a tendency to go ahead and say, well, we're going to start you on some oral bicalutamide, like we always did, and then you're going to come back and get your first hormone shot. And then when I see you in follow-up, at a month out, we're going to talk about adding a second therapy. And I usually try to do it in stages, because at least my patients seem a little bit overwhelmed when I say, all right, we're going to start this, this, and this. But actually, if you wanted to start, a drug like enzalutamide or apalutamide, you could start it instead of the bicalutamide and do it all at once. But
yeah, that's an interesting thing. There's a sort of practicality to getting it approved, pre-authorization, having it come to the patient's accessibility. Pedro, what about you? Are you using bicalutamide?
So that's a great question. So, so when I have a patient with metastatic castration-naive prostate cancer, so I still use it, and I use it because patient has disease, and I worry about T-flare. For the most part, I have, I use LHRH agonist and an antagonist. So with the agonist, we do expect the flare, and for that reasons, I usually, because I don't start them on an anti-androgen on day one, if you will, because oftentimes if I have insurance to approve it, etc. So I try to break it into 2 or 3 visits, if you will. So what I end up doing is start the patient up front on, old bicalutamide, and then give him LHRH about a few days later, a week later or so. And then when a patient comes back to see me again, and we're going to talk a little bit more about treatment intensification, right? That's when I actually do the switch and actually swap them from bicalutamide to whatever novel hormonal agent I'm going to pick for that patient.
So let me ask you this question, because for the longest time we only had LHRH agonists, right? And then in 2009 we got the first antagonist. And now we're talking about patients who have CSPC. They have metastatic disease, whether it's low volume, high volume. Alicia, do you have any preference about agonist versus antagonist? And if you use an antagonist, do you use bicalutamide with that?
So that's a great question. I actually usually use the agonists, and that's just because we traditionally have always used them, and I don't necessarily see for most patients that there's a huge difference, although the agonists we can give a depot for 3 months or sometimes for 4 months. There are even formulations that you could do 6 months or 12 months. So having that flexibility for patients so that they are not tied to the clinic every month, I think is valuable for them. There are some patients with very high-risk cardiovascular disease who have asked me specifically about the antagonists, and I actually work with the cardio-oncologists at our institution, and we tend to use the antagonists in those situations for these very high-risk patients. I would say that the prospective data is not entirely there for that approach, but there's enough of a signal that there's a potential benefit that we certainly do that for those very high-risk patients. Bicalutamide, you could actually start it on the same day as your agonist, which we often do if we already have authorization for whatever agonist we need. So we can start the bicalutamide and the agonist, do all of that on the same day, just to cover the flare. But the antagonist doesn't have a flare because of the way that it's formulated and the way that it works. It's an antagonist, so there's not going to be that stimulation of testosterone, so we do not use bicalutamide in that setting.